Thank you everyone for joining us today. My name is Mariana. I am the CEO and co-founder of the After Cancer. And we do these sessions, and I'm going to share a screen, but we do these sessions every month to talk about different survivorship topics. This month we decided to talk about preventing burnout and compassion fatigue. We all work in oncology. We all go through the emotional roller coaster of caring for patients. A lot of us are either survivors or caregivers. So we not only work with cancer, but we also deal with cancer at home. And so we felt that for December, end of year, holiday season, it's a stressful season. It would be nice to talk about such an important topic. Before we get started, I just wanted to share what we do at the After Cancer. We are a platform and we're really focused in providing survivorship care, making it accessible. Our solution is cost effective. We drive really strong patient engagement, provide reporting on what patients are doing, and we enable to customize the experience. We also drive real patient outcomes that we measure in terms of quality of life. And so we created the After Cancer, this new approach for survivorship care, which is an app with a daily plan that has different types of content, like written content, live group sessions, and chats. And that's really what drives the engagement and care that we provide at the After Cancer. So I know you came here to hear Dr. Janet and Tommy talk, not me. So let's get started. As a first step, let's introduce our speakers. So Dr. Janet Abrahm, could you please introduce yourself?
Hi, everybody. I am a former hematologist oncologist who morphed into a full-time supportive oncologist, if you will. I only see patients with cancer who have supportive oncology issues here at Dana-Farber and Brigham and Women's Hospital. And I started the program here in 2001. We called it palliative care at the time, but to be more accessible, we call it supportive oncology. Patients prefer that. I'm the author of 4 editions of a book for providers now called Comprehensive Supportive and Palliative Care for Patients with Cancer. We're working on the 5th edition or getting permission for the 5th edition now. And it's a pretty comprehensive handbook for providers about all the things that patients with cancer need. And I'd love you to sign up for my newsletter, which is free, and come to my website, which is www.janetabram.com. It's also free. All this is free. We tried to develop resources for clinicians that care for cancer patients. Patients can look at it too, but it is focused on the providers. And there's areas of pain and symptom management, communication, end of life and bereavement, but also special topics, caring for trans patients, caring for LGBTQ plus patients, the hope conversation, VR, all kinds of odd stuff that we've thought providers would like. There's articles, there's videos, and I'm very interested in feedback about what else needs to be there, because I'm more than happy to try to put it there. So that's a long introduction of me, but I'm excited to be part of this session.
Thank you. We're really excited to have you here. So I've shared on the chat both the link of your website, but also the link of your book. Tommy, could you please introduce yourself?
So I'm Tommy Bischoff. My background in training, I have a master's and PhD in marriage and family therapy, and a big focus of my clinical practice has been working with couples, but I also do a lot of grief and loss work. How I got into the cancer space, I'm a cancer survivor myself, and through my journey with that, that's how I met Mariana and the After Cancer, and kind of became a part of that organization, which has been a great space. I hope you all will check out the website and the resources, as it's gotten big. It's gotten national here. So, but yeah, but I'm glad to be here and sharing this kind of conversation together with everybody.
Thank you. Um, so, as I said at the beginning, we all here work in oncology, and it's an incredible and very meaningful work, but it's also very heavy emotionally. There's amazing news and amazing days that come with it. There are news that are hard to take home or to communicate to our patients and their caregivers. And so, Dr. Abraham, I'd like to start by asking you, what are the emotional burdens that clinicians carry that they not often talk about? Like, what is this emotional baggage that providers in oncology carry?
Well, at least when I was an oncology provider, and the ones who I work with at Dana-Farber are so committed to their patients and their patient success. And it's difficult to share with other oncologists when that success is just not happening, and not to blame yourself instead of blaming medicine. That's really where the blame should be, is medicine may fail a patient, but you never will. So part of the problem is that
Medicine.
while the nurses, perhaps in your practice, and social workers and so forth, when they find someone has died, they grieve that person openly. But people forget that the doctor has grief too. And I think what we have is what's called disenfranchised grief. It's sort of like if somebody's aunt was really kind of their mother figure, but nobody acknowledged that. When that person dies, they have disenfranchised grief. They don't have a place at the morning table. And I worry that either doctors remove themselves from it or don't show the clues that people would be welcome to comfort them, so that they have disenfranchised grief, which is terrible. And then there's also unrecognized countertransference, which is that we don't realize how certain patients strike us. And we don't know why we're trying harder with someone than another patient, or we don't know why we're angry at some person. We don't have training in medicine in recognizing our own feelings and understanding that these are not about us, they're about our history and how we've had people like that in our lives. So that when someone who you really sort of reminds you of your mom, you don't recognize that consciously, and maybe Tommy can talk more about that, but you don't recognize it consciously, but you find yourself really, really trying harder and harder to save them, even not having a DNR conversation or not feeling okay about them being extubated, because you don't understand your own grief. I feel like doctors don't understand enough about that kind of unconscious reactions to patients and how it affects their practice and the lives of their patients.
Thank you for sharing that. Tommy, in your experience, what is this emotional baggage that clinicians take home and carry?
Yeah, sure. I think there's a lot of similarity that I have found working with clients in my own journey and my experience working with the doctors and other medical providers. I think there's a lot of similarity in terms of asking these questions of, is this going to work? Um, are we doing the right approach? Am I gonna be okay? Are they gonna be okay? Right? And so I think there's comes up doubt. I think guilt. I think, like Dr. Abrams said, that countertransference. We have our own histories. We have our own experiences that can help us to connect with the people we're working with, but can also, bring up these kind of feelings. And so, I think it's important that we acknowledge them, and I think and share them with our, talk about it amongst our colleagues, and because we can start to feel isolated that I'm the only one who's feeling this way, or feeling unsure or uncertain, and so that can be hard. And so I think if we can start talking about it more amongst ourselves, so with colleagues, and that can help open the door to normalize and start doing something different.
Um, I like what you mentioned right now about feeling isolated, and needing to talk more. Are there any other tools that these professionals can use and that we can use to acknowledge these emotions?
Yeah, I think from like an individual level, I mean, I'm a therapist, so I put a plug for therapy, right? I think having your own space, right? Whether that is therapy or good friends, right? I think we need a community, and that can mean a lot of different things. So if that's the place that you work at and you find colleagues or other employees who you could talk to, or if it is like in a therapy space where, hey, I can explore and process what's coming up for me, why it's there, what can I do about it, right? And develop some new coping skills or ability to navigate that space. Um, so I think there are resources. I think there are, there's groups. There's lots of different groups. They're even online now, like, doing something like this, but that you can participate in and find other people who are in a similar situation that you can connect with. But I think finding your people is important, which can be so many things: family, friends, colleagues. I think we just have to open the door to do it in the first place. So,
Yeah,
I
thank
would say
you.
that we're very lucky in that we have something called Remembrance, led by our bereavement counselor, a psychiatrist, who's a psychologist, PhD psychologist, and a chaplain in our group. And it doesn't have to be restricted to people who've died. We do mention the names of the people who've died every week. And we have somebody assigned to bring a poem or a piece of music, or I think I did the end of Toy Story 3 as my video for grief. And the doctors are encouraged to talk about those meaningful patients and are given support by the PAs, the social workers, the nurses, their colleagues. It's expected and welcome for anyone to talk about a patient who's really been tugging at their heartstrings. And I would imagine that private practices could do this once a month as well, with coffee in the morning and sweets. It's a high carb event, actually. With a social worker, if they have one in the practice, or one of anybody in the practice who's interested in organizing it, making it a normal thing to express your grief and have people support the fact that nobody is blaming you for the fact that this person died. And maybe you could give yourself a break. And nobody's blaming you for the fact that this person isn't taking therapy the way you all want them to. Whatever it is that is tugging at your heartstrings, don't worry alone. Allow people to support you. I think that would help a lot.
if I can add off of that, because I think that gets into it's creating the culture that you want in your workspace, right? As well. What do we value here? What's important to us? And we can set up those kind of rules, like let's have a weekly check-in with each other, right? And how everybody's doing. And let's share experiences, share feelings. And I think that can be very meaningful. But yeah, it's a cultural creation.
Yeah, and it's something that we've had to do at the After Cancer because we've lost some of our patients. And so whenever we hear the news, which might be a daughter calling or the husband or someone in their family, we always like take time to share the news within the team, but also like make space for maybe someone crying. I've definitely been guilty of crying when I've learned that we've lost some of our patients because it touched me so much. But really giving space and yeah, creating that culture. I like what you mentioned, Dr. Abraham, that you do, that remembrance, that little ceremony event where you can make space and remember those patients. Thank you for sharing your experiences here. So both of you have worked closely with patients and families in difficult moments. I would like to hear now from a personal perspective, how do you personally cope with that emotional load of work? So Dr. Abraham, can you share?
Well, I've gotten mindfulness training and hypnosis training, and mindfulness training helps a lot. And before I go into anybody's room, I try to take a moment to just be in that space and to understand that there's a flow of things happening and I don't have to respond to them if I don't want to. I can watch them, I can be professional, but I don't have to respond to them. Whenever possible, I see those patients with a colleague, especially a social worker, but a PA or our pharmacist. Seeing someone with someone else is really helpful, because if they say something like, you can't give up on me. I see patients with oncologists, and the patient will say to the oncologist, you can't give up on me. And I'm able to say, she would never give up on you. She's just worried that this treatment would really ruin the quality of your life and you wouldn't live any longer. And then the oncologist can, get their breath back. Certainly interpreters. We are lucky enough to have in-person interpreters. And that makes all the difference in terms of cultural brokering, helping me understand the patient and family's needs, or chaplain, the spiritual needs. I don't know if you know about Vital Talk, that organization. I would put that in the chat. Vital Talk training I got because my new boss 10 years ago founded Vital Talk. And it's a wonderful communication platform to help oncologists and other people, but oncologists especially, break bad news and then understand when things are going badly. The phrases have been honed so that if you can say, we're in a different place now, that you have phrases and you're not just floundering in that conversation, you have a purpose and a structure to it. I think it's really helpful. I learned to name the emotions of grief and helplessness and sadness and anger in the patient, and then I realize them in myself too. I can feel, it seems to me you're awfully sad. Is that right? I mean, that's part of the whole rubric of it. And I try to set realistic expectations, and I always try to debrief with my team, as I said. Even if it's just for one encounter, I try to debrief with the nurse. I used to think the nurses were blaming me, as I said, because I projected my own feelings of helplessness and grief, and I looked at their faces and I thought they just thought I was the worst doctor in the world. But they were just grieving too. I didn't understand that. It took me a long time. Sometimes they'll make me a cup of tea when I come out of one of those meetings. They take one look at me and they're like, oh, sit down here. I'll heat up a Krispy Kreme for you. And that was awful. That was hard. But I had to be open to that, I had to be open to that. And I certainly tell my fellows and colleagues, after a couple of meetings like I had this morning, I just need to take a walk. Luckily, we have corridors for when it's 12 degrees here, but when I need to go to the healing garden for 5 minutes, I just need to understand that if my expectation is that everybody's going to feel better after we have a horrible conversation, I'm always going to fail. I'm going to fail that one every time. But when I learned that if they trust me, if they know I told them the truth, if we have a relationship, that bond between us can be incredibly helpful, so that I've set the right expectation. I hope that wasn't too long an answer, but I've thought about this a lot because I've been doing this for a long time.
Yeah. And Tommy, before going to you to hear your answer, I just wanted to share something that we've done. And it was from one of our team members. Her name is Cheryl LaCroix. She's one of our peer moderators. She has worked in retreats and nonprofits supporting cancer survivors for most of her life. And she was one of the first team members to join the After Cancer. And so when we started to hear these news, she would always say, go outside and hug a tree,
Oh,
and let that emotion go somewhere else. And so we're known to like spot a couple of trees when we're going for walks, to just hug them and like let it go and think about that person and then let it go, and kind of like embrace that emotion. So if there's trees around your hospital, Dr. Abram, or around any
there
hospitals,
are. That's a great idea. We got plenty of
yeah.
trees. And one of the walks I take is on the Riverwalk. So
Yeah.
I
So
will
don't be
remember
afraid of
that, hugging a tree and letting it go. I
hugging a
think that's
tree
a
and letting it
wonderful.
go. And you have to ask permission.
Oh,
If
I
the
hadn't
tree
thought of
wants
that. There's
to.
probably a spirit in the tree. You're right. There are naiads. Naiads are the spirits of trees. We should ask permission. You're right.
Tommy, over to you.
Yeah. I think we're all in a caregiver type career, right? And so, like any kind of caregiver, you can hit a point where you're burning the candle too much, right? And so we need to be refilling ourselves so we're able to keep giving and keep doing the job and the work that we love to do. So I think taking a proactive kind of stance, right? I love what Dr. Abrams said of being in touch, trying to be aware, whether through mindfulness, through checking in with you and your body to see what's going on, right? How am I feeling right now? Am I still feeling compassion and energy for the work that I'm doing, or am I feeling depleted, right? Am I feeling any kind of feeling really, so then I can address it, right? And yeah, find spaces for you that you can let it out, right? Maybe that's exercise, maybe that's going for a walk, or I need to go throw something around to just release some kind of energy, right? Maybe that is going into a therapy session or talking this out with somebody to share, hey, here are the different parts of me that are coming up. There's a theory model that I'll often use in therapy with clients. It's called internal family systems model. So I love that Dr. Abram brought up the Toy Story 3, because if you've seen Inside Out and Inside Out 2,
Yeah.
it gives a great example of, hey, we're made up of lots of different parts and feelings, right? We may have a part of us that's self-critical, or perfectionistic, right? Or we may have a part of us who worries all the time. We may have a caregiver part, right? We're made up of so many things, and to have a space to understand how those parts work, how they show up, what do they look like, can be really helpful. And then you can manage them in a way that would feel good to you, feel productive, and allow you to kind of keep moving forward. So I know for me, I make use of that space in therapy for myself, because we carry a lot of heavy stuff, and I need a place as well, like whether it is that tree or whether it's somebody I can go and talk to as well. And then I try and engage in activities that rejuvenate me. I love to play tennis. And so when it's not too cold and I can get out and have time, I go do that, because that just gives me energy to keep going. So I think things like that are important.
I like how a lot of these tools that you're sharing, at the end of the day, they're the same tools that we share with patients to go through their journeys, the mindfulness, the being aware, the taking time, the letting go, the therapy. So it's almost like walk the talk. We're very good at telling people what to do, but we also need to make space to walk that talk. Tommy, you were mentioning like be aware. What are those signs that folks should be aware of that basically indicate that they're reaching that burnout or that fatigue?
Sure. I mean, and I think that could look different for different people, but I think some common ones are when you start to feel you're way stressed, and we stop doing things that we normally do, that help take care of us, right? Like maybe we're not sleeping well, our eating schedule has gotten off, we're running late, maybe we start to feel a little, I don't know if jaded's totally the right word, but a little bit of just kind of compassion fatigue, right? And it's like, what does this matter anymore? I think when we start to experience those kind of feelings, is a good time to be like, okay, something's up, something's different, and I need to switch gears and check in. And from that mindfulness level, right, our body is often a great place that's going to show us the cues, the signs, right, of where do you hold tension, where do you hold stress or anxiety or worry, right, in your back, neck, shoulders, chest, right, like, am I having a hard time breathing? Am I holding my breath? It can be different, but I think is a great. Oh, yeah,
Sorry.
oh, you're good. I think our body's a great sign, right? But we got to be paying attention. We got to be looking for it too, because I think we can just run, and then it's like, oh, I'm about to pass out. But so I think those kind of feelings would be things that I would look out for. Or are we getting depressed? Are we getting right? Like I think just in that kind of space, or yeah.
Yeah. Dr. Abraham, do you have
I would just add some of the things that I experienced. Tommy probably did too, but earlier, before I got numb, I think I burned out 2 or 3 times at least. I'm still going. So things like I just can't stop the tough conversation tape playing over and over and over in my head. Like, what did I say wrong? How could I have done better? It's just, I cannot stop the tape. It just keeps going and going and going. Or having a hyperarousal response. Like you see somebody's name on your schedule for the day, and you know you don't have anything for them, and you're just in a panic, basically. Maybe not. You don't recognize it. You just know you do not want to go in that room. Rooms that you just would rather not be in. And believe it or not, in supportive oncology, that happens too. If somebody's in terrible pain and I'm not sure what else to offer, I feel the same way. I have the same hyperarousal response of maybe somebody else could do this better. I'm not sure I can even face this person, even though I know it takes days and days to help them feel better. How about the not rounding on patients when their families are there? That's a really good sign, is if you're doing inpatient work and you try to do it early in the morning or whenever you can, not just fit it around your clinic, but on purpose doing it so that you're avoiding the families.
Recording in progress.
The other thing I hear that is a traditional thing and also happened to me is being angry. I was never angry in team meetings. And at one point, I was angry verbally at a colleague. And some other colleagues luckily came to me and said, Janet, what is going on? We're going to forget why we love you. What's happening? So I think feeling angry at family, coming home and yelling at your family or kicking your dog, or those are signs that that's really not okay. And I think what Tommy said is really important about the emotional exhaustion. And again, another room you don't want to enter is having another goals of care conversation with that patient that you really think you should. You just don't have the emotional energy for it. But those are the kind of boxes I tick off for myself. I try to monitor myself to prevent burnout and compassion fatigue. I don't always succeed. But I keep trying. And I ask my colleagues around me, like they did, to feed it back to me, like, Janet, that is not you. What is happening?
Thank you for sharing your personal experience. Do you have any tips for if someone is in the eye of the storm? They have a really busy day, they're carrying that hyperarousal, they have this patient that they don't know what to do, but they just have to see. What is one thing that provider can do, Dr. Abraham?
Get the nurse practitioner or the nurse, like right away. Almost every practice I know couldn't run without their infusion nurses. Many have social workers. If you can recognize in the beginning of the day, when you look at your list, that this is going to be a patient that I cannot handle, you need to go talk to somebody right away. So even the assistant who schedules patients, they all know these patients. They know them better than you do. And they can understand and be compassionate with you and help you unpack what is it today that is making it impossible for you to have a connection with that patient. And I think it's important to realize that you're not supposed to be empathetic. I want to be compassionate, but I'm not sure the empathy neurons, the mirror neurons, I don't think are that helpful when you're dealing with really suffering people. I think it's maybe better not to feel what they feel, but maybe, as some yoga teachers have taught, to breathe in their suffering and to breathe out compassion. That actually, if you do fMRIs of meditating monks, which have been done, the fMRIs look different if you ask them to feel empathy or you ask them to feel compassion. So I think you may be hyper-aroused because you cannot feel that suffering today. And maybe what you can do is realize, I'm not supposed to do that. I'm supposed to feel compassion for this person. And that has helped me. But I'd be interested to know what Tommy would do.
Yeah, no, I love that. And I know this can be dependent on the type of place that you work at, right? And I know there's pressure for, we got to see the patient, we got to stay on time, we got to do that. I think, though, creating some space, even if it's like, okay, before I go in, I'm going to go get a drink of water. I'm going to go use the restroom. Maybe you have a second to go outside and just like take a break, because that's okay. Like, go calm down, go get some time for you to prepare yourself to enter into the room and be in that space of the grief, the pain, the struggle, because we need that too. And I think that can help us to kind of do it, because I'll do that sometimes, even if it's like, okay, I'm gonna be a little late. I'm gonna go fill up my water bottle. I'm gonna just breathe for a second and then go, hey, sorry I'm a little late. Let's get going, and that's okay. They'll survive that being late part. So I do like that. I think another piece I maybe would add that I think kind of fits with this, but maybe is a little different too, is, at least in the therapy counseling world, the research still shows that outside of the resources and strengths that the client or patient has and utilizes, the biggest predictor of like success from a therapy standpoint in the room of achieving goals and feeling better, right? And I think would fit also in the medical space as well, is it's the relationship that you have with them. So even if it is this, hey, we're not sure where this is going to go or what the outcome is going to be, if we're meeting them on that relational level of having compassion, having understanding, we're still doing some really good stuff, and that's going to benefit them. I mean, that's what I remember the most. My experience, when I was first diagnosed with cancer, the doctor I saw, I think he was perfect for me, and I think that's what I needed. He was just so calm. I asked, I'm sure, the same question multiple times, and just this patience and this understanding, and I needed that. Yes, I wanted I wanted the good support, but I think I just needed someone was like gonna hear me and be with me and sit with me, like, and that was so important. And so I find that in my professional place as well, that's so meaningful. And
Thank you, again, for sharing from that personal perspective. Dr. Abraham, you started talking about this compassion versus empathy, and I actually had a question prepared about that. So I would love for you to help us unpack the difference, but also like how can clinicians maintain compassion, not empathy, without feeling overwhelmed and without being absorbed from the patient's suffering and from the patient's story?
I mean, compassion really protects you. It's a very outward feeling. It's a compassion for another, so that no matter what they're going through, it's not about you. so that you can have compassion, I think, without burning up your own sense of worth. You can have compassion when the treatment isn't working. You can have compassion when anything bad is happening. If you're compassionate, it connects you with the patient in a really beautiful place. Maybe it's because I've studied hypnosis and that's how it feels in hypnosis. There's a very beautiful bridge between a clinician and a patient when there's compassion in the room. It takes away the need to fix it. And you're not suffering because you're not being empathetic. You're not trying to feel their feelings. Those are not helpful. If you're feeling helpless and you're feeling trapped and you're feeling all the things they're feeling, how are you going to pull yourself together to come up with a plan or an approach? But when you're compassionate, you're contained. You're listening really well. You become a very good listener when you're compassionate. And patients sense that you're there with them. And even if they say they expect you to fix it, they don't really always expect that. As long as you're present, as Tommy said, if they really sense that you're present and you're listening and you have genuine compassion, that goes a long way. And it's healing for me, the compassion part. That's why the breathing in the suffering, but you breathe out the compassion. I guess you just have to try it. I don't know, Tommy, what do you think? You just have to do it.
Yeah, no, I agree with that. Because they come in and there's grief, there's loss, loss of health, loss of functioning, loss of somebody just passed away, right? And there isn't a fixing that. And I think that's where, as a provider, right, as a clinician, that can be hard when you do feel that sense of they want you to take care of this and make them feel better.
Yeah.
And we do want to do that. We absolutely want that. But so much, I think, is recognizing when that doubt comes in, or whether doubt or that pressure of like, I'm supposed to do something in terms of fixing this comes in. That's when we need to slow down to be, okay, we can't fix that, but what we can do is be with them and express our care and that we can understand them the best we can from our position. And yeah, feel with them, but not feel for them, maybe would be kind of a similar thing that we're saying here.
And it's also presence, right?
Yeah.
That whole science of presence that is based in the Catholic, religious teachings and so forth, but also Buddhism probably too, that cultivating presence, really being there, is protective too.
And what's a tool that we can use when we're feeling we're being empathetic, but we need to be compassionate? Because it really is a very thin line of being like feeling empathy or compassion. So how can we check?
They're so different though. I guess maybe you should check for the countertransference. Are these my feelings or the patient's feelings? Sort of say, what I do now is, which I learned recently, at least when I come out of the room, I think, how did I feel before I went in the room? And how do I feel now? So if I was kind of okay before I went in the room and I come out profoundly anxious and grief-stricken, well, that's the countertransference, and that's maybe I was using empathy instead of compassion. So I would consciously use the mantra that I said, which is breathing in their pain and breathing out compassion. That's an active process. When I'm in the room, I say to myself, I'm going to breathe in their pain and I'm going to breathe out compassion. Because if you're feeling worse and worse in the room, that's a sign, I think, that you're being empathetic. And that what you need to tell yourself is how to recognize that and to say, I'm not sure I'm being the best clinician for this patient when I'm feeling all the feelings they're feeling. So it's okay for me not to feel those feelings. In fact, it's harmful for the patient relationship if I feel those feelings. I worry that people think they're heartless if they're not empathetic. So they go in trying to be empathetic. And that's what novice clinicians do a lot, is they'll go in and be empathetic and be a mess when they get out of the room and not really helpful. But you're not being heartless. You're being professional if you're not using empathy, I think. I think it's more professional to use the compassion because you can use empathy a little if you need it diagnostically. You can say, okay, so what are they feeling? What am I feeling now? Anxious, depressed, grief-stricken, helpless. Oh, that's interesting. But you need to use your cognitive part of yourself. That's what mindfulness teaches you, is that if you're feeling these things, you're not those things. Those things are in the room, but you're not them. So you can use your cognition and say, oh, that's really interesting. I didn't feel that way when I came in. It's diagnostic. That's what she's feeling. Okay, how can I help her with those feelings? You see?
Yeah.
So I do think they feel really different once you try to isolate them. You'll feel the difference between how you feel when you're being empathetic and how you feel when you're using compassion as a therapy. But it takes, in my case anyway, it took a lot of practice.
Yeah. I can imagine that it takes practice for you to be able to understand those two emotions and your reactions, and then be able to move from one to the other. So that's why I was asking, like, what is the tool or a saying? And I love that breathe in their pain, breathe out compassion. I think that's something that we all can take home today and keep in our minds that we can use probably tomorrow.
I would practice it on a less suffering person first.
Yeah.
Practice it on just anybody who you're asked to see, because it's easier if you learn it when there isn't an enormous amount of affect in the room, I would say. Tommy, again, I'm not a therapist, so.
Yeah, no, this is so fascinating to me too, because in my career and background training, empathy is such a huge part of the therapeutic rapport that we build with them, right? But I absolutely agree that there is this difference, because if we go too into that space, right, we can be overwhelmed. So I was thinking there's an approach, DBT, dialectical behavioral therapy. Mm-hmm. It uses the idea of we've got the emotional side of us, we've got the logical side of us, and then there's this wise mind, is what they call it, in the middle. And so, we want both. We need all of it, right? We want to have feelings, and because that, I think, helps us to relate, put ourselves in their position. But we need to use logic to navigate that too, right? So instead of emotionally reacting, we can observe the feelings in a logical, non-reactive way, and then professionally, like Dr. Abrahm was saying, right, be with the client. So I think it's balancing the two and then finding a good middle for it. Call it the wise mind, if you want. But yeah, I guess that's what I would share.
Interesting.
Mm-hmm.
I wanted to talk about a different topic. We've been covering a lot of emotional fatigue and burnout. But one of the things that I hear a lot when I meet with providers is that I don't have enough resources. I don't have enough things to do to help this patient. It's that feeling of I don't know what to do and I don't have the resources to do that. And I feel that is one of the drivers of burnout, when you feel that there's nothing else that you can do to help that patient, that you're not equipped to help that patient. How do you suggest providers who are with that internal talk navigate that feeling of, I don't have the power, I don't have the resources that I need to support that patient? Dr. Abraham?
Oh, I was going to let Tommy go first, since I can't go first. It's alphabetical, I understand. Okay. Well, I think it goes back to, what does a clinician expect of themselves? And I think what Tommy was saying is they have to look at their inside out. or their parent in there, and try to figure out who is driving this. Why do I feel so bad? Why don't I just accept the fact that I have tried everything? Medicine does not have an answer to this. Why is it not okay for me to accept? Medicine doesn't have an answer, but I will never fail this patient. So they need to process their grief. They need to learn how to process their grief and forgive themselves. Again, talk it over with a colleague, always, to say, what haven't I thought of? What else could we do here? But once they've talked it over and there really isn't something to make this person live longer, then they need to think about what other goals the patient might have. Could they live better? Could they have fewer side effects? Could they have time to make their legacy? Could you, as the clinician, validate that you, as a patient, have tried everything? I heard the oncologist do that yesterday. You have tried everything. You are the best patient. You and your family have left no stone unturned. And I respect that so much. I wish, again, that's a Vital Talk phrase, I wish there were something. And I understand there isn't. And now you still have a lot of work to do. The oncologist, the oncology clinician has to believe that if they're not on therapy, look at all that time and energy this patient could have in the weeks or months left to do their legacies, to meet the people they need to meet, to settle things financially. I tell people, you have a lot of work to do. You're a grandma. You have grandkids that are going to always remember you. Now, how are they going to remember you? People need purpose. And if clinicians understand that even though medicine is not going to make this person live longer, there is so much they can offer, whether or not they enroll the person in hospice and, of course, stay their clinician, of course, not abandoning them. They even have to say that. They have to say, I'm still going to be your doctor, because the patients are shocked. They think if they're not getting treatment that they don't earn a place in the doctor's mind. So I think that if a doctor changes an expectation of what it means to not abandon a patient, it's a little piece, the treatment piece. But the relationship, as Tommy said, the relationship is what is key, and that's what goes on. And if the clinician can feel success is that patient knows I'm there for them, and I will work with them. If they don't want hospice, I'll work with their home care team. We are going to make these last days the best that they can be. Then I think that goal is very achievable. And I wish more oncologists were taught that that's so important to patients and their families. I'm not sure they see that part. I think they worry that there's nothing to balance out the stopping of the chemo, but there's a huge amount to balance out. And patients and families are so relieved that they have time and energy to do this work. That's what I would say.
I like the piece of the purpose, and I would add to permission, right?
Mm-hmm.
Like giving the patients permission and giving ourselves permission in this space to feel and to be all those things. I'd also say, again, I think therapy is a great place to come and discuss if we're having those kind of thoughts and feelings come in, right? Of like, I'm not doing enough. I don't, what's going on? Also kind of checking in past experiences or, your upbringing and all that kind of stuff. That sometimes those messages are influenced by other experiences we've had, and maybe we need to address that and find what happened before, and how is that influencing now. Other kind of ways on outside of therapy, maybe journaling and reflecting your thoughts and writing it down, right? And then challenge them, find reasons for why that's not necessarily true, that you don't know anything or that you're not doing enough, right? Write down 3 things that say that, no, you are. Here's what you have done, right? And so I think there's kind of, again, it all kind of does come to this being more mindful and being more in tune with yourself, to explore and give yourself permission to do that. That just because we're professionals and we're supposed to know stuff doesn't mean we don't need to be taking care of ourselves too. right? And exploring and growing and helping ourselves. So that's what I would add on to that.
Thank you. I feel I learned so much in this session. I'll need to create space to unpack this because it's bringing a lot of memories.